is Ian Cronish. Today, I'm going to be presenting you the results of the CODIAC QoL trial, a randomized trial of depression screening in ACS patients. So why do we care about depression screening in this patient population? Well, to begin with, depression is very common after ACS, with about 1 in 5 having elevated depressive symptoms and 1 in 10 having major depression. Those patients who have depression are at increased risk for recurrent cardiovascular events and mortality, actually double the risk. They also have higher healthcare costs and lower quality of life. Based on these findings, multiple professional societies have recommended systematic depression screening in ACS patients, but thus far, no one had ever tested this in a randomized trial. There are reasons to believe that depression screening may not be effective, in part because patients who are identified to have depression through screening may not be engaged in subsequent depression treatment, and the treatments may be less effective. There are also the potential for harms, including the effect of labeling patients with a psychiatric illness and side effects from antidepressant medications that may be more likely to be prescribed. So with that in mind, we conducted a multi-site randomized control trial of 4 healthcare systems around the United States, and patients were randomized to one of 3 groups: depression screening with the PHQ-8, a commonly used depression instrument, as well as referring patients who had a positive screen to depression treatment that was provided through the study. These patients also had their treating providers notified of their positive screen. The second group was just called Screen and Notify, in which they were screened with the PHQ-8, their providers were notified, but depression treatment was not provided by the study. And then the third group did not undergo depression screening. We enrolled 1,500 patients into the study with even distribution across the 3 groups. And we found, the key findings that we found were, first of all, the rate of detecting depression was only 7%. This was lower than we had expected. The second major finding was that we found no difference in depressive symptoms or in quality of life scores between the 3 groups. And quality of life was our major primary outcome for the trial. We also did not find any harms in terms of increased reporting of side effects from antidepressants, nor increased mortality. So we think these findings are important for several reasons. To begin with, it may be that recommendations for systematic depression screening, at least in the manner that we did this trial, may be premature until there's more definitive evidence for a clear benefit. We don't wish clinicians to take home the message that depression is not important. Certainly, depression does confer increased cardiovascular risk. It also goes along with lower adherence to medical treatment. And if clinicians suspect depression, we certainly wish that they would go on to evaluate it further and get the help of mental health specialists if needed. But the idea of routinely screening every patient for depression does consume healthcare resources and may not be cost effective.